Okay, chapter 41, Pediatric Examinations. We're going to talk about, basically in this chapter, what we do as medical assistants for a pediatric examination. Most of the time, all types of doctors see babies. There are several that don't see infants or small babies at all. But for the most part, as an MA, you're going to encounter a baby at some point. So pediatrics is a specialty of medicine that cares for children from birth until essentially adulthood. Some practices limit care at age 16. I shouldn't say most, but several pediatricians will go until you're 21. That's because there are still some developmental things that happen up until 21. That's used to be like when insurance would stop for children, etc. So pediatricians oftentimes will work up until the kid is 21, 18 at the least, is what a pediatrician will work to with a student. So pediatric patients are examined more frequently than adults. Why do you think that is? Why is it important that we see a child more often than we see an adult? They're growing. They're always changing. There's stuff in their body and their mind that needs to be measured to make sure that they're growing and changing at an acceptable rate. Recommended screening schedule for the American Academy of Pediatrics. So the recommended screening schedule would be right after birth, and then 1 week, and then so many weeks later, and then they would start coming once a month, and then they come once a year once they get to a certain age, et cetera, et cetera. There's a process. Then Medicaid's early and periodic screening, diagnosis, and treatment program is available for pediatric patients as well. This is for patients that have there's two different categories for this. There's patients that have disabilities that provides them with Medicaid, or there's patients that get Medicaid due to income eligibility, and so they are subject to more scrupulous screenings because of the Medicaid company, or the Medicaid portion of the government needs to make sure that those patients are healthy, so there's a more mandated process to that. Pediatric growth and development. So growth refers to the change in height and weight. That's what growth refers to, height and weight. Development refers to the ability to control the body and use verbal and mental skills. There's a table on there's table 41-1 in your textbook that explains all of this. But do you guys remember back in junior year when we talked about Erik Erikson, Abraham Maslow, and I can't remember her name off the top of my head. She wrote On Death and Dying. She's the one, The Stages of Grief. Help, anybody? No? Okay. Anyways, do you remember that from psychology last year, where we talked about the different stages of development? As physicians, they test these kids and their ability and what they've learned. So at 6 months old, they give them blocks and they see if they can pick the block up and they can stack the block. That's done to determine if they have that ability to stack blocks. It's a physical thing, but it requires cognitive ability. So they do different tests to see what the kid is able to do, okay? We have to measure babies, so precise measurements are for essential growth. We need to make sure they're growing. If a child is not growing, it's called failure to thrive, and it's very dangerous, and we need to make sure that a child is growing at a good rate. So what we do is we measure the recumbent length of the patient. You see this picture here? This is what I'm going to teach you how to do. Now, I do not have this kind of measurement system for babies because this is a school. This is not a pediatrician's office. I've actually never even seen one of these in a pediatrician's office, and I worked for one. It's pretty high tech. So what we do is we stretch the baby out up until they're a year old. This is how we measure them. We stretch the baby out, and then we measure from the top of their head to the bottom of their foot, and then we take our tape measure like I showed you a while back, but I'll show you again. Take the tape measure, spread it out, and then you can mark and see how long the baby is that way. So that's the height. The weight is to see how much they weigh. And then we measure their chest circumference and their head circumference. These two numbers are also indicative of how that child is growing. These are important pieces of information. So I've already got printed out growth charts for you guys to use for the activities in your workbook. But growth charts record measurements, and they're available on the CDC's website. If you'd ever like to check that out, click on that link there. It shows the normal growth of infants and children up to 20 years of age, and it compares their measurements with percentiles of children of the same age. So yes, a growth chart basically says, okay, well, little Timmy is in the 45th percentile for children his age. He needs to grow X amount to get caught up, etc. Failure to thrive, as I just mentioned, is an infant or a child who is below the 3rd percentile on a standardized growth chart, meaning they are not growing in an acceptable way. And they oftentimes are given Pediasure or something to boost their weight gain and to promote growth. So here's a picture of growth charts. Okay, so as you can see, there's a pink one and there's a blue one. The pink one is for girls, the blue one is for boys. These are for birth to 24 months. So this is for from the time they're born until they're 2 years old. That's what these record up to. After 2 years old, it goes to the 2 to 20-year-old chart. It's a completely different chart. And I will show you how to measure and how to record on the growth chart. But it's kind of difficult at first when you start using a growth chart, but once you kind of get used to it, it makes sense. But I'll be honest with you, in a medical office, medical assistants don't record on growth charts. That's the physician's job. The physicians are the ones that record, and they're the ones that document the percentile and the treatment plan if the patient is not growing as desired. Does that make sense? So the environment of an office for a pediatrician is very different than a regular office. There's a lot more that goes into it. The office has different protocols to deal with well and sick children. You always want to greet children with a smile. I feel like that goes without being said because children are scared and they're sensitive. And we've learned in the past year and a half or however long that you definitely want to be nice and greet patients with a smile and make them feel comfortable. That's part of your job as a healthcare practitioner of any level. But children specifically need extra comfort and extra assurance that everything's going to be okay because they're scared. They don't understand how things work, so you have to be genuine. But please don't baby talk to a child. You are not a baby. You are an adult at that point in your career, I would hope. And it is perfectly acceptable to speak in a more light tone or to, speak softer or to change the tone and how you communicate. It is really important, though, that you do speak to them on their developmental level. You don't want to use large medical terms like otorhinolaryngology when you're talking to a child because they don't know what that means. So you want to say, okay, well, the doctor is going to look at your ears, your eyes, inside your nose and your throat. And then you can even add like, oh, how cool is that? Make it kind of fun. Make it something that's going to be entertaining for them and let them know that you're there for them so they don't get scared. That's ultimately what you're trying to prevent because a scared child is an uncooperative child. And if you have an uncooperative child, you can't do your job, right? And you need to be able to do your job. So it's about establishing rapport. It is important to gain the child's trust and cooperation, which is why it's important that you show them that you're a person and that you're there to protect them and you're not there to hurt them. Okay? Children are fragile and they're sensitive and they don't understand a lot of things. Now, I'm not saying that children are dumb because they're not. Children understand a lot more than you think they do. But you want to show them that you're on their side and that you've got their back and that it's going to be okay, right? So the play area in a doctor's office, these are kind of a thing of the past. I mean, I don't know how many of you have smaller siblings that you go to the pediatrician office with sometimes. Do they still have play areas and stuff? You have younger siblings. Who does?
My dentist.
Your dentist does? Okay. They still have toys and stuff set up in the corners. That's really, unfortunately, that really should be a thing of the past because of, COVID. But when I worked for the pediatrician, once a week, we would take all of the toys like the blocks and stuff, and we would dump them into a vat of bleach and water solution, like a 1-to-10 ratio. And we would sterilize them or sanitize them. But daily we would literally take Lysol and spray the blocks down. And then there was a sign in our office that said, please do not let your child put this in their mouth. Like, just a common sense kind of deal. And if they did, we would take the block and sanitize it immediately. We'd also have to spray the chairs down every day. This was pre-COVID. We'd have to, those things where they have like the little racetrack and you have to like flip the beads. Kids love those, but they also love to put their mouth and their germy hands all over it. So we would always spray that down. Once a week, we'd bleach it, like big time bleach it. And then, we would use chemical disinfectants to make sure that we were getting everything off of it. But yeah, I mean, that's basically what we'd have to do. And so every day we'd have to do some kind of disinfecting routine so that those children could use those toys the next day. We also had like big plastic, like, trucks and stuff the kids would like run across the floor. We'd have to bleach those and sterilize or sanitize those all the time. And it's definitely, in a COVID world though, I think it would become more of like a every single day bleaching process, like probably every half. So at lunchtime they probably have to bleach them, at nighttime they bleach them again, something like that, I imagine. Or they just really should remove them entirely. And then if the parent wants their child to have a toy at the doctor's office, they should probably provide it. That is the best method to protect children from the spread of disease. So, but that's part of maintaining the play area. You want to make sure that it's clean, and you want to make sure that there's no trash or something that can hurt the child in that area. And, just be conscientious of that. So the role of a medical assistant in pediatrics is to gather data. You need to help that physician or that nurse practitioner gather the information that they need to make sure that that child is growing and is healthy. You want to document information, something that I think you guys have probably figured out by now through your MOS activities and your MindTap, but documentation is a huge percentage of what we do as healthcare providers, not just MAs. So I know those of you that work in the nursing homes probably write stuff down constantly. I fed so-and-so at this time, they ate this, and it was 2 ounces of Jell-O, or however you have to document it. And then at 3 a.m. I emptied their catheter and there was 37 cc's of fluid. You know what I mean? Like, you have to document everything. It's the same way for what we do. It's just a different thing that we're documenting. You want to perform screening tests with your skill and ability level and inside of your scope of practice. So, as medical assistants in the state of Ohio, we are allowed to do Snellen acuity vision screenings. We're allowed to do height and weight screenings. We're allowed to do capillary finger sticks or other different diagnostic testing. But there's absolutely a lot of different things that we can do. And the really cool thing about Ohio is that it's in our scope of practice, we're allowed to do something that the physician tells us to do, as long as we're not violating our scope of practice and there's direct supervision. Because of what, does anybody remember the rule that protects the MA because the physician is in charge? It's a Latin term. Do you remember what I'm talking about? Respondit superior. It means let the master answer. So that means that as a medical assistant, the physician is in charge and albeit responsible for what you do. So if you mess up, it falls on them too. Okay? Do you guys remember that from last year? Trying to remind you a little bit of how last year's conversations went. So then you want to assist the provider. So say you have a patient that comes in because they have a boil on their back and the physician needs to incise and drain it. You could very well be instrumental in that process, setting the tray up for the procedure. You could help pack the hole once the cyst or the boil is drained. Vaccinations, doctor says, okay, well, I just saw a patient in room 3. Go ahead and give him his 6-month vaccination. So you know what that means. And you'll go to the lab and you'll draw up the medications. You'll take them in there. You'll administer the vaccines, and then you'll document that, et cetera, et cetera. And then you want to educate your patients. So remember when I taught you guys, or I showed you the spacer on the inhaler? that's something that you're really going to deal with a lot. If you have a patient that comes in and, like, let's say they have asthma and they're newly diagnosed, mom's really struggling to get this kid to take in the albuterol from the inhaler, it's your job to educate the mother or the father or whomever's with the child and the child on how to administer their medications to themselves. Say you have a patient that's a diabetic and they're a child. That's got to be really scary. Kids don't know how to give themselves shots, you know, like that could be really intimidating. And then you have a very overwhelmed parent that you have to try to console at the same time. Pediatrics is a very interesting and very challenging place to work. You are basically dealing with somebody that has no idea what's going on and somebody who understands what's going on but can't help their child, and it's exhausting and it's devastating at times. And it's your job to educate them and to make them feel comfortable. So again, patient education on how to administer medication, how to take care of a broken arm if they just got their cast on and now they need to take care of it for 6 weeks. That's your responsibility, is to educate that patient and that parent, not just the patient. You're educating the parent too, okay? Does that make sense? Yes? Anybody have questions so far? Cool. So as medical assistants, we are mandated reporters, right? That's something that you've been taught already. If you ever suspect neglect or abuse, you have to report it, okay? I don't care if you have no proof of it. If you think, for any reason at all, that child is being neglected and or abused, you are legally obligated to report that suspicion, okay? Do not wait until it's evident that they're being abused. Do not wait until they come in with bruises on the back of their hairline. Do not wait until the child is emaciated because they're not being fed. Immediately suspect anything, you immediately call Children Protective Services and follow the guidelines that are set up by your facility to report neglect or abuse, okay? You could save lives, but if you let a child go home with a parent that you think is abusing them, 9 out of 10 times you're probably right. They probably are being abused. And you just put that kid back in danger. Does that make sense? So, according to federal law, you have to report any physical or mental harm that you believe may be being done to the child. So neglect versus abuse. Neglect is the lack of withholding of care, meaning this means a lot of different things. For some examples that people don't think about, if you refuse to take your child to the dentist because you don't want to pay the bill, or maybe your insurance is lapped and they get cavities and they get an infection, that's neglect. If you refuse to take your child to the doctor and they keep saying, I want to go to the doctor. So in your textbook, you have table 42 or 41-2. That is a table that depicts information regarding child neglect and abuse in the medical office. Definitely remember, though, that if you have a suspicion, you need to report it. When you're assisting the physician with a pediatric exam, you want to make sure that you've got a rapport with that child and with the provider. Treat pediatric patients as individuals and not just children of their parent. It is very beneficial to communicate with the child and to make them feel as if though they matter. But there's some information that you're not going to be able to collect from a child because obviously they're children and they don't know some things. If it's a 10-year-old kid, they're going to be able to say, on Tuesday, my throat started hurting and now I have a fever. You know, they're going to be able to tell you what's going on. If it's a 2-year-old, they're going to be able to say some things, but they're not going to be able to convey to you exactly what's going on with them. So unfortunately, you aren't going to be able to communicate with that child specifically. You're going to have to communicate with the parent. Going back to child neglect and abuse, one thing to really pay attention to is especially if you have an older child that can communicate for themselves, is if the parent speaks for the child. Again, this is a child that can communicate for themselves. The Gypsy Rose, D.D. Blanchard thing. If the parent communicates for the child and does not allow them to speak, or maybe like coaches them into what they need to say, or you see the parent has like their hand on the child's leg and like maybe they squeeze when they're being asked questions as to alert the child not to say anything. Those are signs of abuse. That is a suspicion. That is worth reporting. I just wanted to pop back and see guys. Okay, so we want to give them the same kindness and respect you give to other patients. You want to treat your pediatric patients like people because they are people. You want to assist with the exam. So you're going to follow basically the same format of a comprehensive physical exam that you would do for an adult, which is head, ear, eyes, nose, throat, you know, the SOAP note, the whole process. And the child is examined from head to toe by the physician because medical assistants cannot examine. We do not diagnose, we do not examine, we do not triage, and we do not treat. We assist, right? If you're giving a child immunizations, you can assist the provider in administering these medications, or you can administer them yourself. A lot of places, doctors, I've actually never worked in a place where a doctor gives the immunization themselves. It's always been given by the MA. It depends on what state you live in and what the laws are. The CDC releases annual recommended childhood and adolescent immunization schedules for children in the United States. You click here, it'll take you to that website. I've also got a copy of a couple years ago posted up on the cupboard up there, and it shows you what immunization a child is supposed to be getting each year, at what dose, etc. So there are different kinds of immunizations. If you have patients that have Medicaid, they receive what would be called like a Medicaid batch of immunizations. So they receive the same immunization, it's just a different batch because the government provides those for the physicians. If you have private insurance, like Medical Mutual, then the physician purchases those immunizations with their office budget and gets reimbursed by the insurance company, okay? So when you work in a doctor's office, if you're working somewhere where they give immunizations, it is nothing for a physician to drop $10,000, $15,000, $25,000 on orders of vaccines. It is absolutely nothing to drop that much money every couple months on those vaccinations. And then when you come in, you get your vaccination, the provider bills the insurance company, and then they reimburse on their scale. Medicaid, so like CareSource, Molina, all of those different like subsidiaries of Medicaid, they provide the physicians with those vaccinations. The physicians don't pay for those, they're government funded. And then the physician doesn't get reimbursed for the vaccination itself, but rather the administration of the vaccination. Does that make sense? I'm kind of seeing some blank stares here. Okay. So when you're giving vaccinations, you have to document them precisely. You always want to document before you give the immunization, you want to document who your patient is, their date of birth, the time that you're going to be, or the date you're administering it, and what you're administering. And then you want to make sure that you document it on their shot record. That is a state law. Children cannot attend school without immunization records.
What if the parent
It's okay, go ahead.
What if the parent wanted the anti-vax?
That's an excellent question. Yes, absolutely, the parent ultimately holds the card and can say, I don't want my child to receive vaccinations. The physician will obviously do their part in educating the patient. It's also, as a medical assistant, it's our responsibility to educate patients, but that is an education conversation that needs to come from a physician. So they're going to try to educate the parent on, what's really what with immunizations, but ultimately it's the parent's decision. If that happens, they have to sign a waiver at the office. Parents ultimately do have the right to say, I don't want my child to have vaccinations. They have to sign a waiver at the medical office that states they have been advised on the adverse reality of not vaccinating your child, and that they don't care, they don't want to proceed with the vaccination anyways, and they sign that release form or that consent form, and then the physician documents that they're not to be vaccinated, and that's just how that works. They can always change their mind. So a lot of times parents will start off with brand new infants and be like, I don't want to inject my infant with a vaccination. Okay, that's fine. But then 6 months later or 2 years later, they decide to go ahead and immunize their child. And now their child has to get several vaccinations over a very short window of time because they waited. So physicians definitely like notify the patient of that kind of issue. But when you do record vaccinations, you'll write them on the chart, but you'll also write them on the booklet that the parent gets. Something that we do as MAs is we do vision screenings. So we know we have the Snellen chart with the big E. That's the Snellen chart we have in the back of the room. But when you're working with children, a lot of times smaller children don't know their letters. So they have one that has like shapes on it or like boats and like teddy bears and like different visual images so that the child can say, oh, that's a bear. Oh, that's a boat. You know what I mean? Kindergarten chart with shapes and symbols. Hearing screening. So infants and small children are based on observation. If you snap your finger and the child like turns to your finger, that means they heard that sound. If you snap your finger and the child's head doesn't move, they don't move in the direction of the sound, then that means that they're not able to hear you. That doesn't really work with like 3 and 4 year olds. You know by that time if they can hear or not, because obviously they will respond or not respond to you. But definitely be aware that like infants, a lot of infants could be, you know, hearing impaired, and we would have no idea if it weren't for the fact of those simple tests. Also, hearing impaired infants cry a lot. They cry a lot. I don't really understand why. I just know that in the stuff that I've seen and in the research that I've done over the years, I don't know if it's because they can't hear or if because they're in pain. I'm not sure what it is, but it seems like hearing impaired infants are fussier than maybe infants that aren't hearing impaired. So don't take that to the bank. That's just something I've kind of picked up over the years. When you're testing an older child for hearing, you're going to use an audiometer. We learned about audiometers in a chapter or two ago. It's where they put the headphones on and it goes, you know, they say, tell me when you hear it beep, and it goes beep, and they push the button. That's an audiometer. Okay, so this picture shows the E's. They said the E upright, the E downward, et cetera, et cetera. And then this picture is the one with like the boat and the zero and the plus sign and the heart and the different shapes shown here. And that is it. That is the end of the lecture for Chapter 41, Pediatric Examinations, okay? Do you have any questions?